All right, this is Dr. Makinde. Hopefully, this is picking up audio. Nicole asked me to record this presentation for the staff members that were unable to make the presentation a couple weeks ago. Obviously, vaccines are a big deal right now, and there's a lot of questions that have come up amongst the nurses and the staff, and really, even in my practice over the last few years, really a lot of questions about vaccinations. So I wanted to just give a primer on this, and there was a good conversation that we had when this presentation was given in person. If anyone has questions after watching this, they can get a hold of Nicole or Camille, and they will shoot them to me. We may end up posting this somewhere as well, and we'll find a way to answer questions if anyone has those. So, vaccinations. What is a vaccine? Basically, a vaccine is a biological preparation meant to stimulate the body's immune system to identify disease causing microorganisms, whether viruses or bacteria, or sometimes even our own cells, and then uh, destroy them. And then also, once they've been destroyed, create a memory bank in order to destroy any future microorganisms that are similar or the same virus or pathogen. Historically, these have been prophylactic, so it's always been to prevent a future infection and subsequent disease. But recently, vaccines can also be therapeutic. A couple of examples of that are melanoma and pre-malignant HPV lesions. This is probably the most important part of this slide is the purpose of vaccines, excuse me, and that's to prevent the contraction of a potentially deadly disease and decrease the risk of passing that disease to others. And the key to this is the word disease. It's not to prevent the contraction of a virus or the infection of a virus. When viruses infect an organism, they may or may not actually cause disease. A really good example of that is COVID-19, which is obviously what we're dealing with now. COVID is the disease. That's what the D is. But the virus is a SARS virus. And so there are millions of people likely who have contracted the SARS virus but never develop COVID, the disease. And so a vaccine is meant to prevent the disease and not necessarily the infection. And we'll kind of go into that as we go on. But that's something that's a little bit nuanced that a lot of people don't really pay attention to. So as of right now, if you don't count COVID, there are 25 uh, World Health Organization licensed vaccines to prevent infection. And these can basically be broken up into two groups. The first group is sort of the routine vaccinations. That's kind of the way I look at it. And those are the things that you know you would need before going to school, just as you progress through your well child checks, and then some adult vaccines, depending on your age. Things like, measles, chickenpox, um, tuberculosis. And then the other group of vaccines are the specialty vaccines, is kind of the way I look at those. And those are typically for people that are traveling to endemic areas or areas where um, some of these diseases that aren't as prevalent in the US or in the Western world are still endemic. Things like yellow fever or uh, uh, anthrax, um, where you get a special series before you travel. This table basically looks at a couple examples of just how effective vaccines are. Now, in my opinion, and really in anyone that studies this stuff, and most physicians will tell you that vaccines, from a healthcare standpoint and especially population health standpoint, are probably the most successful thing that has been done. Um, there's plenty of diseases that affect human beings and plenty of treatments that are effective, but really the most successful thing on a large scale as far as treating and preventing disease has been vaccines, because it's better to just not have that disease around than have to deal with its sequelae. This table on the left, hopefully this pointer is visible on the recording. This table on the left looks at measles cases in the United States. The peak of cases was in the kind of mid to late 1950s. We had around 760,000 cases. The first vaccine that was approved was in 1963. And as you can see, after that, the rate of infection began to steadily drop. Um, the second dose MMR was recommended by the CDC, I believe in 1988 or 1989, and that followed another precipitous drop to where the all-time low of cases was 37 in the early 2000s. Um, this trend has started to go back up, and this has been tied to some of the issues with um, people opting out of vaccines. This MMR autism myth that was started based off of a questionable, I'll put it at best, paper, um, has led to some of the decrease in vaccination and increase in measles coming back. But just looking at the trend, uh, without vaccinations, we would basically still be up in this over 100,000 cases per year region, where some years are a little bit higher, some years are a little bit lower. Um, on the right, this is smallpox as a share of deaths in London. Um, the pink to the left is before vaccine was available, and on the right, the green is after vaccine was available. And so what this graph is showing is if you looked at all the people that died between 1700 and 1900, the proportion of those deaths that was attributed to smallpox, again, was before the vaccine ranging anywhere from about 5 to 15, 17%. But kind of if you do a trend line, it's roughly around 8 to 10% throughout that time. After a vaccine was introduced, this dropped again precipitously to basically a very, very small percentage of deaths. This spike here was in 1870 to 1875. This was the smallpox outbreak in Europe that was a result of the Franco-Prussian War, where there was a significant amount of unvaccinated French prisoners of war that infected civilians in Germany. And then over this 5-year span, it basically spread around Europe again. This table underneath that is polio deaths in the United States, pre-vaccine to the left, post-vaccine to the right. Again, you can see after a vaccine was available, essentially polio cases, which is the green graph, were eliminated. I know in my medical career, I've never treated polio. I've seen patients that had the sequelae of polio, and those were all people that had traveled or immigrants from countries where vaccination was not routine. This bottom graph, again, is another one looking at measles, basically kind of showing the same thing. The other thing to note about these graphs is the amount of time from an institution of a vaccine to cases dropping to levels where it's not really seen. If we look at MMR, the first vaccine was approved in 1963. The all-time low was in the early 2000s. And so that's something, again, when we're looking at COVID and now having vaccines and what that means for the future going forward, obviously there is no sort of poof magic bullet to make things go away. This is kind of a long haul thing, and we'll get back to that later. This is a quick video on how vaccines work. Hopefully there's sound. If there's not, you can just YouTube how vaccines work, TED Ed, and it should bring this up, but it gives a great primer and sort of brief overview of vaccinations.
In 1796, the scientist Edward Jenner injected material from a cowpox virus into an 8-year-old boy, with a hunch that this would provide the protection needed to save people from deadly outbreaks of the related smallpox virus. It was a success. The 8-year-old was inoculated against the disease, and this became the first ever vaccine. But why did it work? To understand how vaccines function, we need to know how the immune system defends us against contagious diseases in the first place. When foreign microbes invade us, the immune system triggers a series of responses in an attempt to identify and remove them from our bodies. The signs that this immune response is working are the coughing, sneezing, inflammation, and fever we experience, which work to trap, deter, and rid the body of threatening things like bacteria. These innate immune responses also trigger our second line of defense, called adaptive immunity. Special cells called B cells and T cells are recruited to fight microbes and also record information about them, creating a memory of what the invaders look like and how best to fight them. This know-how becomes handy if the same pathogen invades the body again. But despite this smart response, there's still a risk involved. The body takes time to learn how to respond to pathogens and to build up these defenses. And even then, if a body is too weak or young to fight back when it's invaded, it might face very serious risk if the pathogen is particularly severe. But what if we could prepare the body's immune response, readying it before someone even got ill? This is where vaccines come in. Using the same principles that the body uses to defend itself, scientists use vaccines to trigger the body's adaptive immune system without exposing humans to the full-strength disease. This has resulted in many vaccines, which each work uniquely, separated into many different types. First, we have live attenuated vaccines. These are made of the pathogen itself, but a much weaker and tamer version. Next, we have inactive vaccines, in which the pathogens have been killed. The weakening and inactivation in both types of vaccine ensures that pathogens don't develop into the full-blown disease. But just like a disease, they trigger an immune response, teaching the body to recognize an attack by making a profile of pathogens in preparation. The downside is that live attenuated vaccines can be difficult to make, and because they're live and quite powerful, people with weaker immune systems can't have them, while inactive vaccines don't create long-lasting immunity. Another type, the subunit vaccine, is only made from one part of the pathogen, called an antigen, the ingredient that actually triggers the immune response. By even further isolating specific components of antigens, like proteins or polysaccharides, these vaccines can prompt specific responses. Scientists are now building a whole new range of vaccines called DNA vaccines. For this variety, they isolate the very genes that make the specific antigens the body needs to trigger its immune response to specific pathogens. When injected into the human body, those genes instruct cells in the body to make the antigens. This causes a stronger immune response and prepares the body for any future threats. And because the vaccine only includes specific genetic material, it doesn't contain any other ingredients from the rest of the pathogen that could develop into the disease and harm the patient. If these vaccines become a success, we might be able to build more effective treatments for invasive pathogens in years to come. Just like Edward Jenner's amazing discovery spurred on modern medicine all those decades ago, continuing the development of vaccines might even allow us to treat diseases like HIV, malaria, or Ebola one day.
So, looking at possible side effects from vaccines, basically any vaccination, really every vaccination can cause side effects, but overall, typically they're minor, just lasting a few days. Rarely they're serious, and this is something that's continually monitored by the medical community, as well as there's a task force or a reporting system that's the United States Vaccine Adverse Event Reporting System, or VAERS, that anytime someone has a reaction that could be potentially serious or because of a vaccine or thought to be from a vaccine, it gets reported to this system and it's investigated. I'm going to go through just a few examples of vaccines and their typical side effects, their rare side effects, and their even more rare side effects, just to kind of show that it's essentially the same for almost all of them. The first one is the DTaP. Basically, with the DTaP, the more common reactions are going to be soreness and swelling where the shot is given, fever, fussiness, feeling tired, loss of appetite, and vomiting. Outside of the soreness from the area where the shot is giving, a lot of these responses are actually due to your immune system mounting a response. Even with infections of pathogens, a lot of times you feel the worst because your immune system is now upregulated and fighting off the infection. Vaccines do the same thing, but typically it's a lot lower level than when you actually get the pathogen and become infected. Rare, you'll have seizures, especially in if a fever is present. In older children who get the DTaP vaccination, they may have more diffuse swelling as opposed to just localized. And then very rare, again, this is with millions of vaccines administered, you'll have long-term seizures, coma, which can be related to the seizures, lowered consciousness, permanent brain damage, and then allergic reactions or anaphylaxis that if you go into anaphylaxis, this is a life-threatening issue. And so because of that, death is also a potential risk if someone has an anaphylactic reaction. I put this table in here, or this map of the United States, just to show how very varied the rates of immunization are across the country. Um, the blue are the highest rates. Green is there's no data available, and red are the lowest rates. And it's interesting because some people think at this point this is sort of becoming a political thing, but if you look around the country, the highest rate is in Texas of vaccination. So, and some people would say, well, that's more of an anti-vaccination state, and really the message is that it's it has nothing to do with politics. Hepatitis A, this is um, a map of vaccination rates from 2013. Again, varies throughout the country. But side effects, the more common ones are going to be soreness, redness at the injection site, and then fever, headache, tiredness, again, immune system response, rarely vasovagal syncope. And that's something that's associated with any injection. Any physician or healthcare provider that performs injections knows that some people pass out when needles come out or if they get an injection. And then very rare, again, anaphylactic type reaction. And if you have anaphylaxis, that is a risk for death. So that is also a very rare associated risk. Hepatitis B, again, soreness where the shot is given, fever, rarely passing out with the injection, and very rare, again, anaphylaxis or other serious injury. And that's usually referring to people who do pass out and then have a head injury or something like that because they fell. Again, death is always associated with anaphylaxis, so you have to include that in there. This is a map of the world, hepatitis B vaccination rates in 1-year-olds from 2017. This highlights that this is essentially a third world problem at this point when it comes to vaccination, similar to the way polio and things like that are when you look at the whole globe. Haemophilus influenza, again, side effects, redness, warmth, swelling where the shot is given, fever. Again, the immune system is upregulated. Rarely vasovagal syncope, and very rarely anaphylaxis. And again, death is associated with anaphylaxis, and so that's listed there. HPV, kind of a broken record at this point. Soreness, redness, warmth at the injection site, fever, headache. Again, the immune system is upregulated. Rarely vasovagal syncope, and then very rare, again, anaphylaxis, which leads to some of these other sequelae. This is a map, again, of HPV vaccination rates by adolescents in the US. Inactivated influenza vaccine, and this is not the live vaccine. Again, on occasion, the most common things are going to be soreness, redness, and swelling where the shot is given, systemic fever, muscle aches, and headache. Again, the immune system is upregulated. This does have a very small increased risk of Guillain-Barré syndrome, which is a neurological condition. Seizure caused by fever in kids when it's combined with the pneumococcal as well as the DTaP vaccine. And then again, vasovagal syncope. Very rare allergic reaction or anaphylaxis, which could lead to death. I put this table in here just looking at some of the myths about the flu vaccine, or at least the inactivated one. One is the flu shot will make me sick. It's impossible for the flu shot to make you sick from the flu. You may have some of the same symptoms as if you were sick, but that's because your immune system is upregulated. But it cannot cause you to be sick from the influenza virus. It's just your immune system being upregulated. Second myth is I got sick with the flu after my shot. The vaccine doesn't work. There's a couple points with this. One, The flu vaccine is typically given during cold and flu season. And so a lot of times it doesn't mean you're not going to get colds. You're still going to you can still get any kind of viral pathogen that's around at the time and we're indoors. It doesn't necessarily mean you got the flu. The second thing goes back to that first point I made when I discussed the purpose of vaccines. It is, again, not to essentially prevent you from getting infected with the pathogen, is to prevent you from developing the disease. And so with many vaccines, the actual primary benefit is that if you do get infected, your symptoms and your disease burden or your morbidity and ultimately your mortality is a lot more decreased. And so if you do get sick, you're not as sick, you're not sick for as long, people aren't in the ICU, your body's able to actually fight it off. And so the benefit isn't necessarily like, oh, I'm not going to get sick this year. It could be that if you do get sick, it's not as severe. Last myth is that my immune system's strong. I'll just get, if I get the flu, I'll get the flu. I'll be out for a few days, maybe a week, and I'll bounce back. And for most people, that's true. That is something that, if you look at the population, it's not killing millions of people. The issue is, again, for you personally, it way decrease the likelihood of you having serious illness. But then there's also people around you who may not be able to get the vaccine and who may be vulnerable and have serious illness. And so the more people that are vaccinated, the viral pathogen is less likely to be passed from person to person. And if it is, it's a less virulent strain. And those that aren't able to get the vaccine or are immunocompromised are protected. MMR vaccine, same side effects that are more common: soreness, redness, or rash at the injection site, and then some of the systemic signs of the immune system being revved up: a fever, swelling of the glands in the cheek or neck. Rarely you will have seizures, typically often associated with fever in children, some temporary pain and stiffness in the joints. There has been some rare cases of pneumonia, of encephalitis, thrombocytopenia, which is low platelet count, and then very rare, again, anaphylaxis, and then a life-threatening infection for people who receive the live vaccine that are immunocompromised. This table on the right is, again, looking at MMR vaccine rates in the U.S. The white states, there's no data. The light blue and the light gold are states where vaccination rates are greater than 95%. And then the dark blue and sort of the dark gold are states or counties where vaccination rates are less than 95%. Again, varies throughout the country and really from county to county. In summary, from vaccinations, as far as side effects, or serious side effects, anaphylaxis is the big one. If anyone has a history of anaphylaxis to a vaccine, that's a serious discussion that needs to be had of the risk of obtaining vaccines, based on what's going on in the community environment and in each individual situation. Systemic infection after administration of live vaccines to immunocompromised persons, that is historically something that really shouldn't be done, and is a real risk if you are an elderly patient or someone with cancer or on chemotherapy or a newborn. Live vaccines, or pregnant ladies or pregnant women, live vaccines shouldn't be given. And then I've listed a few others that are sort of known and documented over the years: intussusception after rotavirus vaccine, Guillain-Barré after the flu vaccine. Obviously, if someone passes out and they're standing when they get the vaccine, or they're in a chair and they fall and hit their head, there's a risk of serious injury based off of blunt trauma. Viscerotropic disease associated with yellow fever vaccination. This is basically a multi-organ inflammatory or response. Sometimes it can lead to multi-organ failure. This is very rare. The last case of this, actually, I'm not aware of a case of this recently. It can also cause neurological disease. Smallpox can cause eczema, progressive vaccinia, which is basically another multi-organ issue. This is associated with immunocompromised patients who get a live vaccine. And then paralytic polio, myelitis with the oral poliovirus. And these, again, are all issues with live vaccines. So in looking at the two vaccines that have been approved now for COVID-19, there's a couple other vaccines that should be coming down the pike soon. But at the time that I put this together, which was in mid-December, these are the two that were approved, are Moderna and Pfizer. These are mRNA vaccines. And basically, what an mRNA vaccine is compared to some of the more traditional vaccines is that with traditional vaccines, a protein from the virus or the bacteria or whatever pathogen you're vaccinating against is injected into the body. It is not something that can cause the disease or infect you, but it has properties that are unique to that virus that the body recognizes as foreign and then begins to make antibodies against that. So that if you come in contact with that pathogen in the future, your body's able to fight it off. With this particular vaccine, um, it's an mRNA vaccine, and what that does is it bypasses collecting any proteins from the actual pathogen or virus, and it injects information and instructions to make a protein that is from that virus or pathogen. And with the SARS virus, it's the spike protein. And so instead of injecting the spike protein, you inject instructions on how to make that protein. So your body makes that protein. That protein is then presented on the cell surface, and then the immune system recognizes that and then begins making antibodies against it. And so it potentially is safer for people with immune system problems because it's almost the complete opposite of a live vaccine. And it's not even proteins from the pathogen. Your body's making the proteins, and then the immune system makes antibodies against it. After that spike protein is made, the mRNA is broken down. It never enters the nucleus. And so that's one of the things that we'll talk about in a little bit, where there's some discussion in the general public about whether or not this affects your DNA. The only way it would have anything to do with your DNA is if it was to enter the nucleus of your cell, of your cells, which it doesn't. So Moderna versus Pfizer, just kind of comparing the two. The Moderna vaccine is 2 doses, 28 days apart. The studies were done in in folks 18 years of age or older, and so it's approved for that. The absolute contraindication for this, again, is if there's a history of anaphylaxis, and I think at this point that would still warrant a discussion with your primary care provider or whoever provides you health care on the risks and benefits of that. Pfizer is 2 doses, 21 days apart. Theirs is approved for folks 16 years of age or older because they studied it in people 16 years of age of older. And again, the absolute contraindication for this is a history of anaphylaxis. The ingredients, basically both of these vaccines have the same ingredients. It's essentially mRNA, again, which is the message to or instructions to your cells to start making proteins, the spike protein, lipids, and those are listed there, the different lipids that are in each vaccine. And then tromethamine and tromethamine hydrochloride on the Moderna vaccine, that's basically a buffer. It basically makes it so it's not acidic. And then sugar, sucrose, and some sodium. The Pfizer vaccine, again, mRNA, lipids, potassium, sodium, and sucrose. And these are things that are, obviously compatible with the human body and on their own do not cause any adverse side effects or changes to your body. The clinical trials used on these, the Moderna trial had around 1,500 individuals, 18 years of age or older, that received at least one dose. And this was, well, we'll talk about a little bit what the sort of ethnic background of the study participants was, but the aim was basically to show that it prevented COVID-19, which it did. The duration of protection is unknown because this is a new disease, and we'll find things like that out as we go along. The Pfizer vaccine had 20,000 individuals. These were 16 years of age or older. Again, was shown to prevent COVID-19. And again, this is the disease, not SARS infection. And the duration of protection is unknown. So total, before this was approved, around 35,000 patients were in these studies. Based off of their data, the risks For the Moderna vaccine, and this again is very similar to every other vaccine that we have, injection site pain, tenderness, swelling of the lymph nodes in that same arm, and some redness. Pfizer vaccine, basically the same thing, injection site pain, swelling, redness, swollen lymph nodes. The general side effects, and these are basically because the immune system is mounting a response. For Moderna's fatigue, headache, muscle pain, joint pain, chills, nausea, vomiting, and fever. For Pfizer, same thing, just general malaise, fever, headache, muscle pain, chills, joint pain. For anaphylaxis, for the Pfizer vaccine, there's been 6 cases as of, I would say, mid-December when I was putting this together. Um, no deaths. For Moderna, at that time, there was no cases of anaphylaxis. I'm now aware of one case in Boston. It was actually a physician. This was around Christmas time. Um, who had racing heart, I believe some swelling. He self-administered an EpiPen or epinephrine, um, and was not hospitalized and didn't have any prolonged symptoms. But I think that may be one case of anaphylaxis for the Moderna vaccine. Obviously, with both of these, as more and more people get the vaccines, this data will continue to change. And so the remainder of this is sort of common questions that have come up from different staff members and patients that I've seen regarding the COVID vaccine and really vaccinations in general, but more specific to COVID. The first is, are there any potential long-term side effects? The answer is we don't know. These vaccines have only been around now for maybe a month and a half. And in the studies, the short-term side effect profile was basically just like every other vaccine. The only way to know if there's any long-term side effects is going to be time. Can I still get COVID-19 after receiving the vaccine? The answer is yes, you can. But the issue here is risk. The risk of getting COVID-19 is much, much lower. And the risk of severe illness is even lower than that. Will the vaccine be necessary every year? Again, we don't know. There's already variants when we look at the proteins and the sort of molecular and cellular structural makeup of the SARS vaccine that causes COVID. Right now, the thought is that the vaccines that have been approved will still be effective against it because they all still have this spike protein that antibodies are being made against. But if it changes and that protein is no longer the same structure, then it might be that there would need to be a vaccine every year. Can people who are vaccinated transmit the virus to others? Again, the answer is yes, you can, but the risk is much lower, especially as more and more of the population becomes vaccinated. So the ethnic background of the study is 82 or basically 83% white, 28% Hispanic, about 10% Black or African American. So this is about 3,500 African Americans, 4.3% Asian, so about 1,500 Asians, about 2.3 multiracial, so maybe about 700-800 people, 0.5% Native American or Alaskan Native, 0.2% Native Hawaiian or Pacific Islander, and then 0.6% did not report. And this becomes important when we look at, some of the reasons people don't get vaccinated. As we know in medicine, there are plenty of examples of parameters that are looked at that are different across racial and ethnic backgrounds. One of example I like to use is kidney disease or renal function. The normal values for African Americans are different when it comes to renal function than they are for Caucasians or really every other race. And so the way when we look at studies, if they're tested on a large population and the demographics of that population are essentially the same, it's not necessarily accurate to extrapolate that to the remainder of the population because of the differences in how our genetics process medications and respond to different things. And so that's something to just kind of keep in mind. How are the vaccines produced so quickly? This is something that comes up a lot. And for me, the answer is twofold. And I don't necessarily, I think it's a poorly worded question, but this is sort of how it's asked, is vaccine production, actually producing the vaccine is really the same speed. What is different and what changes is how fast a vaccine is approved. And the two reasons vaccines and really most medications take a long time to approve is, one, you have to show that they work and that they don't hurt people. And the only way you can show that they work and they don't hurt people is by having a high number of people in the studies. And in sort of the scientific literature, we describe that as the N. N just stands for number. And one of the reasons why vaccines and medications take so long to approve is because it's hard to get people in these studies. That's why you'll see that in order to enroll people in studies, you pay them, you give out, Amazon gift cards, all kinds of incentives and gifts to try to get people in studies. Because if I do a study and I only put two people in the study and one person gets better and the other person doesn't, I can say, well, it works in 50% of people, but that's essentially meaningless. And that would never get approved because you don't have enough people. The higher number of people you have, the more your data actually means something. And if it shows a positive benefit, then you've met that criteria. And with COVID, obviously we're in a pandemic, millions of people have been getting this disease. The world is shut down. It wasn't hard for them to get people involved in these studies. The second component that causes the delay in getting vaccines approved and medications approved is basically the bureaucratic and review process for getting these things done. It's just, I mean, if anyone's been to the post office or the DMV, you understand how efficient the government can be in reviewing things. And this is basically the case here. When the world shut down because of pandemic, that becomes priority number one. And there's different systems put in place to expedite the review process. Everything else is put on the back burner. And so they had enough people in the studies to show benefit, and the review process was expedited because we're in the middle of a pandemic. Are there people with conditions who should not get the vaccine? So again, we've kind of spoken about this. Anyone with a history of severe allergic reaction should probably, I would say, delay vaccination until there's more data, or discuss with their physician that knows them the risk and the benefit. And if they do get it, they should definitely get it in an environment where they can be supported in case they have a reaction. Is it safe in pregnancy or in children? There's no information currently. There were no children under the age of 16 in the Pfizer study, and 18 was the Moderna study. There were no pregnant women in those studies. This may have changed as of now, but I don't think any pregnant women have been studied. The American Society of Maternal-Fetal Medicine, I believe, recommends discussing with the primary providers or their OBs for pregnant women regarding the risk and benefit. This is another one of those where time will tell. Another question that comes up: why not just get COVID and have natural immunity? And so this is going back to the purpose of vaccines. For most people, this actually, is not unreasonable, because for most people, and again, we're talking the whole population, they'll be asymptomatic and it won't really change their life going forward. The issue is no one knows what category they fall into until after they've gotten it and gotten really sick, or they've gotten it and were lucky enough to get tested and know that they have it and didn't have symptoms. And so it's essentially a game of roulette, whether or not you're someone who will have severe symptoms and be in the ICU, or someone will have no symptoms. The other piece of it is some people do recover, but they have long-term issues. I have patients now that are on blood thinners because of blood clots, and these are patients of all ages, patients that were on ventilators in the ICU, myocarditis, all sorts of systemic issues where they were perfectly healthy before then. The other piece of that is if you are someone who gets infected with SARS and develops COVID, but you're asymptomatic or have minimal symptoms, and especially if you have minimal symptoms or no symptoms, you are able to pass that on to people around you. You don't know if those people around you are people who will develop severe disease or no symptoms. And so unless you're living alone or in an island, you just getting COVID and having natural immunity, you don't know how it will affect you individually, but you also don't know how it will affect those around you and your loved ones and that sort of thing, and the people in your community. And so this brings me to the last slide, which is, in my opinion, really the real issue when it comes to the vaccines, especially the COVID vaccine, but really vaccines in general. The vaccine debate, and I put that in quotation marks because, in my opinion, it's people try to use science to try to get around the real issue. Um, it's not about science. When you talk about science, you're essentially talking about the scientific method, and the scientific method is the same reasoning and steps that were used to develop cars and planes and iPhones and computers and all the things that we use every day that people believe in, for lack of a better term. With vaccinations, it really is a question about um, individual freedom, autonomy, and the society that we live in. If you look back at the previous slide at the rates of infection of measles, for example, or smallpox or polio, and how they were before vaccines were introduced and what they were after vaccines were introduced, the biggest takeaway for me is that measles did not go away when vaccines were developed for them. Over time, as more and more people were vaccinated, the rates of infection and the rates of serious disease burden decreased as more and more people were vaccinated. An example we can use today is something like chickenpox. When I was a child, everyone got chickenpox. Now, if you work in a pediatric clinic, no one gets chickenpox because they all get vaccinated. And as a society, we're always constantly asked to buy into certain things. Sometimes it's taxes, for example, or if the light is red, you stop, or if the trash pickup is on Tuesday, you put your trash bin out and you take it back in. You don't just throw your trash in the street. Those are all things that we have to do to keep our society going the way that we are accustomed to it going. When there's a pandemic of any type, virus, coronavirus, Ebola, SARS, anthrax, our society breaks down because we have to change how we live. The only thing that we have against pandemics of infectious particles are vaccines. If you try to wait for a treatment to treat the disease, the graph that you see where it just oscillates up and down for decades, and in years where it's high, you have to lock everything down and separate people and shut down society. In years where it's low, you open things up a little bit. That becomes the normal way of life. The only way to reduce that disease burden and have society return back to something that is normal, the only tool we have for that are vaccinations. And so the society is asking people to buy into that. And the difference between this, in my opinion, and some of the other areas of society that we've been asked to buy into, for example, stopping at red lights, paying taxes, and all those other things, is that with vaccines, you're asking to do something to your body. And as an individual, there are many people who that is a line that they draw, where it's, I do not feel comfortable with society or the government forcing me or asking me to do something to my body based off of an overall societal benefit. And as a physician and as an individual, I have no problem if people are uncomfortable with that and they make decisions based off of that. Where I have an issue with is when people try to use science to defend that position, because that, again, that doesn't make sense. The scientific method is the same everywhere. What does make sense to me is if you look at the history of medicine and in our society, especially in America here, there are plenty of examples where different segments of the population were taken advantage of, were abused really in the name of science and developing things, whether it's people in the military, whether it's African Americans, Native Americans. And so if you already come from a position of distrusting of institutions in the government, it can be a very hard decision or a very hard choice to say, I'm going to trust these entities with putting something in my body. The caveat to that is this is the only thing that we have to fight pandemics. There is nothing else. And so if the majority of people are uncomfortable with putting something in their bodies that is the only tool that we have to fight a pandemic, then the way our society is now is the way that it's going to be. And that's kind of it. If you have any questions, feel free to reach out to Camille or Nicole. I'll probably again post this somewhere. And I hope everyone's staying safe. Thank you.